views and comments of the hosts and guests are not necessarily those of the station.
Hi, I'm Nicole, Jacinto. Join us on Healthline with 𝗏𝗏𝗵𝗹 as we discuss the latest health and medical topics with doctors from 𝗏𝗏𝗵𝗹. For a healthier and uplifting lifestyle, tune into Healthline with 𝗏𝗏𝗵𝗹 on DZRJ 8:10 a.m. Radio Bandido TV. You've got questions, we've got answers.
Watch and listen to Healthline with 𝗏𝗏𝗵𝗹 every Monday from 5 p.m. to 6:30 p.m. airing on Sky Cable Channel 224 and on all DTT boxes. Simulcasting online on Facebook and YouTube. Listen and watch on your mobile devices. Just search DZRJ Radio Bandido.
You're about to experience Healthline, a show where doctors from 𝗏𝗏𝗵𝗹 interact with you for a healthy, uplifting lifestyle. Moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome to Healthline.
Hi, everybody, and welcome to Healthline with 𝗏𝗏𝗵𝗹. I'm your host, Nicole Jacinto. It's Monday. Yes, it is Monday. It's 5 p.m. And you know what that means. It's time to get together, as I said in the merch plug, and talk about having a healthier, uplifting lifestyle with doctors, of course, from 𝗏𝗏𝗵𝗹, one of the best institutions in the country. We have subject matter experts, and we talk about different topics on the show that could be relevant to you yourself or someone you know, someone you love. And it's just good knowledge to have in general. And today we are going to talk about heart arrhythmias. What's that? Well, we're going to find out today with Dr. Paul 𝗄𝗏𝗁. Good afternoon, doctor, and welcome to the show.
Good afternoon, Nicole. Thank you for welcoming me.
Of course. Yes. Am I pronouncing your name correctly? 𝗄𝗏𝗁 or 𝗄𝗏𝗁?
Yes,
Okay.
correct. 𝗄𝗏𝗁. Yeah.
𝗄𝗏𝗁. Okay. So tomato. I'm just joking.
It's
Okay.
okay.
So,
Yeah.
Dr. 𝗄𝗏𝗁, you are a cardiology specialist, so you're
Yeah.
cardiologist, and we are talking about heart arrhythmias today. Can you tell us exactly what is a heart arrhythmia, basically?
So heart arrhythmia is an irregular heartbeat that can be fast or it can be slow or it can be a normal rate, but it's kind of irregular. So the patient will feel it and we can investigate it.
Okay. So is a heart arrhythmia, based on what you just said, is a heart arrhythmia always felt by the patient, or do they sometimes get diagnosed without really knowing?
Yeah. So most of the time,
Mhm.
actually patients come to us because of symptoms. But
Mhm.
you're correct, Nicole. Sometimes it's what we call an incidental finding.
Mhm.
So, for example, they'll get an annual physical exam, and in the ECG, we'll find something that is irregular there, wherein, in fact, they will deny any symptoms. So, it can be both. It can be the patient can be symptomatic or asymptomatic.
Okay. All right, doctor. And now, you said that heart arrhythmias can be either, the rhythm is irregular, basically. That's what it is. Now, it's either too slow, could be too slow, could be too fast, could be like it's normal, but then there are irregularities. Are these the things that we talk about, like when they say bradycardia, tachycardia, or something else? Could you tell us, I guess, what are the different types of heart arrhythmias?
You're correct, Nicole. So, bradycardia is when the heart rate is kind of slow.
Mhm.
So tachycardia is when the heart rate is above 100. So of course we can have a normal heartbeat and it's on the high side and we'll still call it tachycardia. But when there's an irregular heartbeat, then that is an arrhythmia. So the heart arrhythmia can be something that is benign,
Mhm.
meaning it's like a skip beat. It will show on the ECG. The patient might not feel it. And the patient usually is just for clearance. And the dilemma is what to do with the arrhythmia that we see in the ECG. On the other end of the spectrum, it can be a very fast heartbeat that can be life-threatening. And sometimes the first presentation is actually cardiac arrest or a fainting episode. That was because of a very fast heartbeat. There's not enough blood going out of the heart. So it's kind of tricky because it's really a big spectrum. It's either something that is benign as something that we can ignore or something that can present as at the first time a cardiac arrest.
Yeah. Like the first time you would know is somebody just fainted, and then just giving your example, and then you find out, oh, they have tachycardia. Like it's, you
Uh,
said heart beats too fast. It also, the blood doesn't pump out enough. It's just like it's, I guess the heart's like a muscle, no, beating that way. And so just to like, it's interesting when the heart beats too fast, not enough blood goes out. Because I mean, people like me who are not medical professionals and cardiologists certainly would think that, oh, no, that means more blood's coming out, but apparently no. Okay.
yeah.
When it comes to or bradycardia, doctor, like the heartbeat's too slow. I know it's difficult to like pinpoint an exact range because individuals are different, but what would you sort of consider like a slow heartbeat or bradycardia? And what, yeah, so that first, like 40 beats per minute, 60 beats per minute, that type of thing.
Yeah, so you're correct. It's a case-to-case basis. For example, athletes who are participating in sports usually will have a very slow resting heart rate. So in their case, for example, a 40 beats per minute is actually kind of normal and expected. So, but in an elderly, for example, a 40 can be too slow.
Mhm.
So in the bradycardia arrhythmias, what we look at is what we call the level of defect. So for example, it's a normal heartbeat that is just slow. So the defect is above. Then it's usually something that needs symptoms before we need to investigate.
Okay.
So just to give an example, so a healthy, for example, 40-year-old man, no symptoms, just in the APE, annual physical exam, we find the heartbeat is in the 50s. Just to let you know, 60 to 100 is a normal heartbeat range. But if the patient's heartbeat is 50, he is or she is asymptomatic, and it's just a normal heartbeat that is kind of slow, then usually we don't need to investigate unless we see something else. But if the defect or the problem is lower down, meaning there's what we call an AV block. So this is getting technical.
That's
But
all
if
right.
the heartbeat is is
You'll explain
slow,
it, I'm sure.
yeah. So and the defect is below, meaning the problem is lower down in the heart.
Mhm.
Even if the patient is asymptomatic, that can lead to just what we call cardiac arrest. So the heart can stop anytime and there can be no warning, meaning it's just a sudden the patient event. The patient cannot stop it, and if the patient is lucky, the heartbeat can restart.
Mhm.
So it's not the number, but the level of the block. So
Mhm.
the number is just secondary. And if the level of the block is high, we need symptoms to say it's serious. But if the
Mhm.
level of the block is low, then we don't need symptoms. It can be life-threatening.
Okay. Thank you, doctor. So that's when it comes to like lowered heartbeats or bradycardia. And thank you for giving like the typical normal range that because
Yeah,
you know, you did say, I mean, it's a case to case basis, but or did you say that? But I guess that's what you meant. I mean, that's what it
correct.
is, case basis. And um it's very good that you noted like in athletes, usually it's a bit lower, their resting heart rate. So when we say resting heart rate, that means when you're not doing anything, when you're not like exhausted climbing stairs or whatever it is, or exercising, then your heart rate could be lowered. You gave the example of a 40-year-old man. What if he was or still is an athlete? Then that would be something you consider. Like, let's say he's a football player, or he swims a lot, or he does triathlons. Then that would be something you consider apart from the block that you mentioned. Yes.
So
So, yeah.
for athletes, yeah, even if they get older,
Mm-hmm.
they usually retain that slow heartbeat. So if the 40-year-old man after 20 years becomes older, if his heartbeat is still in the 50s, that is still considered normal as long as it's a normal heartbeat. It's just slow.
Yes.
And the patient, yeah, is asymptomatic. So that can still be acceptable.
And with tachycardia, doctor, you said it's is it 100 and over, or like 100 above 100, meaning 101 and over?
Yeah, by definition, so it's 101 and over. So tachycardia just means a fast heartbeat. If it's an arrhythmia, it needs to be something that is not the normal heartbeat. So we can have what we call sinus tachycardia. So it's a normal heartbeat that's just above 100, so 101 and over. So for example, if the patient is anxious or excited or nervous and the patient feels palpitations, and when we record his or her heartbeat, it's just 120 and it's a normal heartbeat, it can be a normal response or what we call reactive tachycardia. Same thing as when a patient is febrile or has fever or is dehydrated, or for example, just sat down from a long walk to the clinic, the heart rate can be fast. But it doesn't mean that there's an arrhythmia. We need to document something that is irregular in the heartbeat.
Okay. And that's usually done through an ECG.
Yeah.
First step. Okay. So doctor, can you have both a heartbeat that's too fast and too slow? Like, have you encountered patients where at times their heartbeat is too slow and it's too fast, and it's not like a very normal response to like whether they're stressed out, they just exercised, or is there a combination at the same time? Like, have you ever encountered patients where perhaps you're monitoring them, or they come into you for an incidental finding, or because they already know they have a problem, like where at times they have a heartbeat or a heart rate that's too slow and then one that's too fast? Does that happen?
You'll be surprised, Nicole. That's actually a common finding in the elderly. So
Ah,
they will have, yeah. So they will have an irregular heartbeat. So when the irregular heartbeat lasts for a very long time or is very frequent enough, their normal pacemaker or normal heartbeat becomes suppressed. And when the irregular heartbeat stops or terminates, they usually faint because it takes a while before their normal heartbeat kicks in. So that is what we call 𝗪𝗪 syndrome. So tachycardia and bradycardia occurring at the same time. So the older the patient is, the higher the percentage of that happening, because it usually requires, as we get older, our
yes.
normal heartbeat actually decreases. And
Okay.
as we get older, the irregular heartbeat frequency or prevalence increases. So that's why the combination is more frequent in the elderly, typically about 70s or 80s. And they're not very uncommon. They're actually quite frequent in their age group. But of course, in the general population, it's uncommon. But in their age group, it's really something that we see often in the clinic.
Yes. So in terms of being common, it is quite common, and to have like to have both, to have either
Yeah.
one, or it's either too slow, too fast, or to even have a combination. And can I
Yeah.
ask you, when it comes to how common it is, when it comes, you did mention the elderly, and as you said, as people grow older, our heartbeats tend to beat a bit slower. When it comes to, let's say, the younger population, how common is it? Like, how many, perhaps in your experience, patients have you seen? Maybe even children or adolescents or adults? Don't ask me where I fall into that category. I'm serious.
Yeah. It's, yeah, it's difficult to say. So when we're talking about the arrhythmia, it's difficult to get a prevalence, meaning how frequent it is in the general population, because it's not all the time that patients will feel it. So sometimes it's an incidental finding. Literature would say that worldwide, the prevalence of arrhythmias is somewhere in the 5 to 10% region for everyone, meaning all comers. So of course, it depends on how stringent they screen the patients or where they screen them. For example, if we screen in the hospital, we tend to get more arrhythmias. But if we screen in the clinic, we tend to get less. So, but it's difficult to get a true prevalence because most of the time patients do not feel it. So we're not sure. For example, if we do a ECG on 100 people, chances are we'll find something that is different, not the regular heartbeat, in more than 10 people there. But because they're not feeling it, we'll not be able to screen them.
And
Yeah.
okay, doctor, you mentioned if you do the ECG or the screening, whatever the process is, and we can circle back to that later, in the clinic, you don't, it doesn't manifest, I guess, as much as when you do it in the hospital. Is that because like people might be nervous, or, I mean, what would be the reason for that? Like, do you catch it more, or does it show up more? As you said, if you screen 100 people, 10 might exhibit an abnormal heart rhythm or an irregular heart rhythm. And I mean, is it that? Because I know, like, sometimes when people, even if they're just getting an executive checkup, they're like, oh, like, is it the nerves? Is it the setting? Is there something, do you consider all of that? Or why in clinics is it like less likely to be tracked?
So
Or
you're correct. Yeah. In the clinic, patients are more relaxed. Of course, they're not relaxed all the time, but
yes.
they're more relaxed instead of in the hospital. So, of course, usually when they get admitted in the hospital, either they go through the ER, or it's usually nerve-wracking there, a lot of people. So, and of course, if they usually get admitted because of an acute illness, so stress, anxiety, acute illness, viral infections can trigger arrhythmias. So the sicker the patient is, the more chances we'll be able to catch something that is an irregular heartbeat. The less sick the patient is, the less chances we will catch it. So that's why if we screen in inpatient population, more likely we're able to see more patients with arrhythmias. If we screen the general population, more likely we will not be able to see anything, not much, yeah, because they're not very sick.
Does does the irregular heartbeat, is it also connected to somebody's blood pressure, or not really? Or is there an somehow correlation in
Sometimes there is an interaction. So, for example, if the irregular heartbeat is inefficient, it's
Mhm.
very fast. So remember, the heart is a pump.
Mhm.
It's not all going out of the heart. So the blood is not just going out of the heart. It also needs to fill with blood.
Mhm.
So there's what we call a filling time. If the filling time is very slow, very fast, I mean, because the heartbeat is very fast, there's not enough blood to go out of the heart because it did not fill with enough blood in the first place. So if the tachycardia or fast heartbeat is long enough, it can lower down the blood pressure. Sometimes it can also cause a cardiac arrest because not much blood pressure or not much blood flow goes around the body.
Mhm.
So sometimes if the heartbeat is too slow, meaning it stops, or it's too slow, there's a compensatory response. The body sometimes raises the blood pressure. But sometimes it can also go down. The blood pressure can also go down because the heart rate is too slow. There's not enough blood going out of the heart. So usually there's a relationship to the blood pressure, but sometimes the blood pressure can still be normal with an arrhythmia. So there is a relationship, but it's not all the time there.
Yes. Thank you, doctor. Just clearing up some stuff, questions that would normally come up. And also
Yeah.
really for explaining that, because we also don't want people to be like, oh my God, I have high blood pressure. Maybe, it means that I have this or that. The best thing, of course, to do would be to really go through a thorough screening and with someone like you. And as you said, it may not it may not manifest in the blood pressure. Your blood pressure may be normal, but apparently you have an irregular heartbeat. Now, doctor, can I ask you, what um what are the symptoms that someone might experience if they have an irregular heartbeat?
Yeah. So of course, the most common one is a fluttering feeling. So they feel that their heart beats kind of fast if they have what we call a tachycardia.
Mhm.
So most of the time, we don't feel our heartbeats, or we are unaware because we're busy. So yeah. So but when we're resting, sometimes we feel our heartbeat because we're not busy. So we are resting, we're about to sleep, so we feel our heartbeat. But once it's very fast, even when we're busy, the patient can feel it. So if the fast heartbeat causes the blood pressure to go down, they might also feel dizzy
Mhm.
or feeling pain. Or, of course, if the heartbeat is very fast, they might feel tired or have chest pain. On the other end of the spectrum, if the heartbeat is very slow, they also might feel dizzy and feel faint or feel weak,
Yeah.
sometimes to the point that they feel that they're about to collapse. So it's a big spectrum, but in general, they'll feel their heartbeat either irregular or fast, even when they're busy. Yeah.
Yeah. Thank you, doctor. And as you're saying these symptoms like the fluttering, like, kind of like the butterfly in your chest or a bit of pounding or
Uh,
faint, or as you said, of course, when you're busy, you're not exactly our heart beats all the time, so we're not like counting it or completely feeling it. And then you did say that sometimes when you're busy, you can feel like, wait, there's something there, or there's some type of chest pain. Um, or the feeling of weakness. All of this sounds like those songs that people write about falling in and out of love. But no, it could be an irregular heartbeat. I'm not saying that I'm a
yeah.
songwriter, and we need all these like metaphors and stuff when it comes to the heart. But it's just funny how it correlates. So I think people would really understand that feeling, and it might not be love. It might be an irregular heartbeat. Okay, so doctor, when it
Correct.
comes to to these to these but you did say stress and other things, so that it's a careful balance. It has to be someone like you who could diagnose it properly, and other medical professionals. Doctor, you mentioned some of the symptoms, and we've talked about the kind of irregular, like the types of what defines an irregular heartbeat. I have so many questions on this topic actually, so I'm just gonna shoot. But can we talk about
Sure.
first, like what causes? What are the, if there are like so many causes, like basically, yeah, what are the most common causes, if not all the causes, if you can talk about that, of an irregular heart?
Yeah. Sure, Nicole. So we'll talk about first the cause. The cause can be congenital or acquired. Maybe you're asking about the triggers. So in
Okay.
the congenital, for the cause, it's usually there's a structural problem in the heart.
Mm-hmm.
So usually for congenital, the trigger is adrenaline. So
Adrenaline.
usually, yeah, when the patient is tired or playing, the patient might feel chest pains or might collapse. On the other hand, the acquired can be as benign as just stress or taking a lot of coffee. So people who take a lot of caffeine in general will have a lot of palpitations. It can just be skip beats or normal heartbeats as because of the caffeine, the adrenaline. So, of course, lack of sleep can also trigger it. If the patient is, of course, nervous, so you'll be surprised. Some elderly people will say that they have chronic nervousness. But when we screen, actually, the feeling of anxiety and nervousness was due to an irregular heartbeat.
Oh,
So yeah, it's a cycle. So if the patient feels excited or nervous, we think it also triggers the irregular heartbeat. And the irregular heartbeat triggers more nervousness. So it's a bad cycle.
yeah.
So as I said earlier, yeah, acute illness, viral illness can be triggers. As the patient gets older, the chance of the irregular heartbeat um, occurring or being triggered by a structural problem in the heart
Mhm.
becomes higher. So typical example, a patient who is hypertensive,
Mhm.
so the blood pressure causes some problems in the heart. So those problems lead to irregular heartbeats. Sometimes, if the patient has a weak heart, those that structural heart disease, the weak heart can also trigger the irregular heartbeat. And of course, as we get older, it's generally wear and tear. So it's just the natural history of things. So remember the longevity of people nowadays worldwide is about 70s. And yet people are living beyond 70s, already 80s and 90s. And at that point, their normal pacemaker can already be damaged, or they might have an irritable heart. So things like that. So it's difficult to pinpoint one trigger. So, but in general, adrenaline is the most common trigger for either an acquired or congenital patient with a normal heart or an abnormal heart.
Thank you,
Yeah.
doctor. And I'm so happy. I learned today about like how you may be nervous can trigger irregular heartbeat. Irregular heartbeats can also trigger more nervousness or
Correct.
anxiety. Then it's a cycle that feeds on itself.
Yeah.
And when
Mm.
we talk about congenital, let's say the structure of the heart, doctor, I just have questions like, for example, if somebody has a heart murmur, or let's say a floppy mitral valve, first thing that comes to mind, or mitral valve prolapse, can that give someone an irregular heartbeat? And which one would you treat? The floppy mitral valve or the irregular heartbeat? Okay, sorry, I gave you like questions in a row.
That's okay, Nicole. So you're correct. So that is one of the more common, what we call causes or etiology of the arrhythmia in the younger population. So the floppy mitral valve causes backflow of the heart to a chamber that should not have the backflow. So the backflow irritates the heart. So because we cannot treat the floppy mitral valve, we usually just give medications for the irregular heartbeat. So the arrhythmia usually caused by a floppy mitral valve is usually not life-threatening. But the patient usually is very symptomatic. So the patient might have fainting episodes or near fainting episodes, a lot of palpitations. The patient might get easily tired because of that. But usually the patient just needs reassurance because if we see that it's just that, so maybe you're seeing where I'm going. So it's the irregular heartbeat or the arrhythmia may not be important. Most of the time, what's more important is the cause. So if the cause is not something that is serious, the symptoms might be worse, but it's not life-threatening. On the other hand, yeah, so some patients might not be very symptomatic, but the first symptom can be a sudden cardiac death because the cause is something that is dangerous. So if we can treat the cause, we treat the cause. But if we cannot treat it, for example, it's an anatomic problem. For example, if you have a car and brake system fails, even if you replace the brake fluid multiple times because it's a physical problem, the brake system will still fail. So it's just like the floppy mitral valve. So it's a physical problem. There's nothing that we can do by giving medications to it. We only suppress or give band-aid treatment for the palpitations, for the symptoms. And just more importantly, reassurance that it's nothing that is very dangerous or serious.
Yes, I agree with the reassurance part. I do. And I think that way, somebody, if it's not serious, but the underlying cause is causing the symptoms. I'm so glad you mentioned reassurance because it might even, in time when they know, when the patient knows and they can treat that symptom, then it might not even happen as often because people get nervous about things that they have also. And sorry, go ahead, doctor.
Yeah, go. I was just about to say, so majority of the patients that we see just needs reassurance. So they'll have incidental findings on the ECG. They don't have any structural heart disease. They're perfectly okay, except that either we see it on the ECG or they might have mild symptoms. And what's more important is to go see those patients, to go see their doctor so that we can advise them whether it's something that they need to work up for or it's just something that they can ignore, or is it something that will go away or something that they need to live with for the rest of their lives. Is it something that needs medications or maybe just relaxing techniques, or is something that is what we call stable, meaning it will just be there like that, or something that may be worsening over time. So things like that, all those questions we cannot answer without finding out the arrhythmia and finding out the cause. So they should see their doctor and not be scared, because 90% of the time they just need reassurance. Yeah.
Thank you, doctor. And I know someone when we were a lot younger.
Yeah.
She had a lot of asthma attacks. I don't think she has asthma anymore, or it doesn't manifest. But it's really like she was at the school like clinic, and they said, "Eh, maybe you should see a doctor because your heartbeat seems irregular." And when that friend of mine saw the doctor, it turned out she did have an irregular heartbeat. Do you often get cases like that? Like, I know it's an incidental finding, but someone can hear it and it turns out to be true. Like, there's maybe, I don't know if asthma was the cause or because of the way she was breathing, but there's like other things that could also lead to it aside from, let's say, heart murmurs or nervousness or stress. Just
Yeah. Yeah, so it's actually quite common, Nicole. So the medicines for asthma actually also affect the heart. So so the medicines, the inhalers do trigger or irritate the heart. So the medicines themselves can cause arrhythmias. Most of the time, they're what we call benign, meaning they're not life-threatening, and they usually are self-limiting or they go away. So asthma, because it's an acute stress to the body, can also trigger arrhythmias. So even without the medications, if the patient has difficulty breathing or is coughing, there's a coughing fit, and that in itself can trigger arrhythmias. And if that is the only cause, so how to prove when the coughing fit goes away or when the patient is breathing well, the arrhythmia also goes away, and we don't find anything abnormal in the heart, then usually that just needs reassurance. It's just that it's the anxiety and the difficulty of breathing, the nervousness causing the arrhythmias. So just needs some work from the doctor. Yeah.
Okay, thank you, doctor. Also, we do have, sorry, I got distracted because we have some questions that came in, but I think we do need to take a short break right now before we continue with the discussion. So I'll be back with lots more questions for you, doctor. I'm just going to throw them out there. And we do have questions from people who are tuned in today. So if you don't mind, doctor and audience, go grab your coffee, use the bathroom already. I don't know what you're doing. Doctor will not say this, but if you're smoking, go ahead, have a break. That's bad. I'm not endorsing it. I'm just saying I know how people are. We'll be right back in a couple of minutes. Stay tuned to Healthline with Makati Med.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. Jacinto from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable at Makati Med Care Access, Araneta City. What's more, Makati Med Care Access is the only single-use hemodialysis center in Araneta City. It's now easier for patients to avail of renal care services right in the heart of Cubao. We offer health screening and diagnostic procedures in this facility at affordable rates. You can get services such as mammogram, ultrasound, lab procedures, ECG, and many others. We believe that access to affordable, quality, and compassionate healthcare is a basic human right. And we at Makati Med Care Access Araneta City are doing our best to make this possible to more people. You can find us at the ground floor of Manhattan Plaza Tower 1 in Araneta Center, Cubao. We are open from Mondays to Saturdays from 7 a.m. to 5 p.m. and Sundays from 7 a.m. to 4 p.m. For inquiries, you may reach out to us at the numbers below. We look forward to serving you here at Makati Med Care Access, Araneta City. This is Dr. 𝗛𝗶𝘁𝗵 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable through Makati Med Care Access at 𝗛𝗶𝘁𝗵. Available for outpatient care services, our 𝗛𝗶𝘁𝗵 site offers consultation and diagnostic procedures such as medical assistance, hospital admission assistance, blood pressure monitoring, laboratory tests, and X-ray, among others. This is really convenient for those residing in Makati and nearby areas who do not want to go to the hospital to have these treatments and procedures done. We believe that access to excellent quality and compassionate healthcare is a basic human right, and we at Makati Med 𝗛𝗶𝘁𝗵 are doing our best to make this possible to more people. We are open from Monday to Saturday at 8 a.m. to 5 p.m. at the third floor of 𝗛𝗶𝘁𝗵 in Makati City. For inquiries, you may reach us at these numbers. We look forward to serving you here at Makati Med Care Access 𝗛𝗶𝘁𝗵.
You're back with Healthline, keeping you healthy. Moderated by Nicole Jacinto.
Hi, everybody. Welcome back to Healthline with Makati Med. I'm your host, Nicole Jacinto. We're talking about irregular heartbeats today. But before we get back to the discussion with Dr. 𝗂𝗶𝘁𝗵, I would just like to say thank you to the doctors that I personally know who have treated me, or people that I care about in Makati Med, like Dr. Victor Gisbert, Dr. Gary Lopez, Dr. 𝗛𝗶𝘁𝗵. I mean, with doctors, people, I just remind the audience, it's always, of course, a personal relationship that you can find, but that you have to find with them. And I know a lot of times it feels like, hit and miss, but I can't speak for every single person. That would be dishonest of me. But for the doctors that I've received good, just above and beyond, what a doctor should give. I did mention 3 of them, and I'm sorry, the rest I can't mention all of you, but I just wanted to say that specifically today and remind people about, we see the commercial played and we hear it. There's the latest equipment and also techniques or new technologies, new things being applied in Makati Medical Center. So just keep that in mind for your next executive checkup. I've also gotten an executive checkup there. Boy, was it fun. For me, at least, I'm just like that. Okay, doctor. Back to the discussion. Wow. Okay, I've got a number of questions for you. Also, our viewers and listeners have some questions for you. They all kind of gathering together, but I'll read their questions. The way they asked them, the way they sent them in a couple of minutes. So, folks, hang on to get your questions answered. Doctor, just because I was mentioning earlier some things like perhaps a heart murmur or blood pressure, other issues, the asthma, just to bring out how some of these things are discovered or if there's any relationship to it. And I'm so happy that you mentioned that. I mean, there's explanations like asthma medicine can make your heart beat faster. It's a temporary thing, and as you said, patients just need reassurance. Are there other cases? I'm curious where, like, perhaps other causes, like people who apparently have low blood sugar or something, will come to you because my heart's not right, and that could be a cause, or let's say just being malnutrition. I mean, nutrition is like you're not getting. It doesn't mean like you're too thin or too fat or whatever the regular thing that someone wants to define, but you're just not getting the right. I mean, apparently your vitamins are off and all of these things. Is that something that you find also as a cause or perhaps related to the irregular heartbeat?
Yes, Nicole. So, for example, if your sugar is very low, your body will send signals to you that says that it's stressed. So usually the symptoms that the patient will feel is palpitations, they will have cold sweats, and they might feel weak or feel dizzy. So how to tease out the diagnosis? Of course, they need to check their sugar at the time that they're symptomatic. This is typical among patients who are diabetic. So if you have diabetes, the sugar can also not all the time be high, it can also be very low just because of the nature of the diabetes or because of the medications. Malnutrition, as you said, Nicole, is the one important trigger. So, for example, in a patient who lacks the proper electrolytes, is not eating correctly, or maybe had a drinking binge. As we know, alcohol can trigger, irritate the heart and can also cause dehydration because it makes us pee. So if you have a lot of electrolyte loss, it can trigger irregular heartbeats or arrhythmias. If the patient is obese, chances are there's a good chance the patient has high blood pressure. Obesity and high blood pressure are both risk factors for arrhythmias, especially in the patient who is sedentary. So those can trigger. So different things can actually have some relationship with arrhythmias. So we need to find out. You're correct. We need to tease out those relationships because they can help with the diagnosis and management.
Thank you, doctor. Okay, before I get to the questions of our audience, okay, guys, konting pasyensya lang. And when talking about an irregular heartbeat, is there if there is a case where a patient exhibits like, okay, it's irregular because it actually stops, like and you can see it on the ECG, like for a moment there or for a few moments it actually stops, no, and then so that would be considered an irregular heartbeat if the cardiologist determined. Okay,
Yeah. So
really a real case, so I'm talking about without trying to reveal names of the person. Now,
yeah.
that person, when the person exercises or given a stress test, which we'll talk about later because I'm sure it's one of your
Yeah.
diagnostic tools, the first 15 minutes, the patient is like just cannot, like, hardly move, walk, and it's just like basically the stress of exercise and it's there. But after the first 15 minutes, when the person's exercising and like the heart rate is elevated, it is where it's supposed to get to, there's no skip beats. Okay, what can you say about that?
So for the first question, you talk about the slow heartbeat.
Beats, man.
So that is one of the more scary parts or scary diagnostic results. So when we see a patient's heartbeat stopping, we need to find out if there's a reversible cause. Most of the time, it's because of what we call iatrogenic, or because of medications that the doctor might prescribe for other causes. And sometimes it slows the heartbeat too much, or sometimes electrolytes or thyroid can be abnormal. And then we need just to reverse these causes. The problem is when there is no reversible cause. So, for example, it's because of age, degenerative, and then that patient usually will require a pacemaker. So the pacemaker is an artificial heartbeat that is a hardware that is implanted in the patient's body. So for the second, the stress test, as we said earlier, majority of the arrhythmias are triggered by adrenaline. So when we use the stress test to tease out whether it's a dangerous one or not, what you just said is actually a good sign. So if the patient has a lot of irregular or skip beats at low level of exercise or even at rest, but when the patient exerts and the skip beat goes away, then actually that's a good sign, because majority of the dangerous heartbeats are actually triggered, or the cardiac arrest happens when they exercise. So when the exercise suppresses the irregular heartbeat or arrhythmias, then that is a good sign. But that is just one clue that we need to look for. So there are a lot of clues that we need to look for, but in that particular example, that is actually a good sign.
Okay. Thank you, doctor. All right. Now, before I ask you how we go about, okay, why don't we just go straight to how do you diagnose an irregular a heart arrhythmia?
So
And
there are,
sorry, go ahead.
go ahead, yeah. So there are two scenarios. It's either they already have it's an incidental finding, so they already have an ECG. It's for an annual physical exam, and they present it. So in that case, we do not need to make guesses because the clue is already there. So they usually need some reassurance. So we'll just need maybe an ultrasound of the heart, maybe a stress test, or other tests to determine if the skip beat is dangerous. So if the heart of the patient is weak or there is some form of heart enlargement, then it might be dangerous. Or if the skip beats happen or become worse with exercise, then it might be dangerous. So that's the first scenario. The second scenario is the patient has symptoms, but they come to you, they don't have any workup yet. So the dictum is we need to see what is causing the irregular heartbeat. So we need symptoms as well as documentation of their heartbeat at that particular moment. So because, for example, when we do heart monitoring, if we do what we call the Holter, it's a 24-hour heart monitoring. So we send the patient to the heart station where the people there will attach the device. It's a small device, hardly noticeable. And they wear it for 24 hours or even longer. And they do their normal activities. If we do that to 100 people, 90 of those people will have some form of irregular heartbeat. And they might be insignificant. So the only thing that becomes significant is that when they report symptoms at that particular time, that we saw the irregular heartbeat. So for example, the patient has palpitations, and at that particular time, the Holter revealed a normal heartbeat. Then we just reassure the patient that most likely that symptom is not because of an arrhythmia, because we have proof that when the patient had symptoms, the heartbeat at that time was normal. So it can just be anxiety or stress or maybe the caffeine from the coffee that patient took a while ago. So on the other hand, if it's because of a skip beat or what we call a bradycardia or tachycardia, then the same thing as scenario one, we find out if the heart is weak or there is heart enlargement, or the patient has maybe a blocked artery. So blocked arteries can trigger dangerous heartbeats. So we do a stress test. So if the skip beats become more frequent with adrenaline or exertion, then that is a bad sign. Then maybe we need to investigate fully the coronary arteries or the arteries supplying the heart if there's blockage there. So as you can see, we need to actually visualize the cause or the heartbeat at that particular point. And more importantly, we need to find out if the heart is strong or weak. So just to give you an example, a patient who is maybe a teenager with a congenital heart disease or what we call supraventricular tachycardia or SVT. So it's just a highfalutin term for a very fast heartbeat that happens. We're not sure about the trigger. It can happen as frequently as 4 times a year or even once every 3 years. The patient is very symptomatic. The patient will go to the ER because of palpitations or chest pain. The heartbeat might be 200. And then we just give medications or we shock the heart. The medications stop the irregular heartbeat. And when we investigate, the heart function is normal. Then we know that that patient does not have a life-threatening irregular heartbeat. So we just reassure, give treatment, and there's some permanent cures for some irregular heartbeats, just like procedures for what we call SVT, like ablation that we can offer. But more importantly, we need to find out, aside from looking at how the irregular heartbeat looks like on the ECG, more importantly, the heart structure. If it's good or the heart is strong, chances are it's not a life-threatening arrhythmia. So that's how we go about things. Thank you.
Thank you, doctor. Okay. I would ask you to walk me through it again and please correct me if I'm wrong. So when you diagnose somebody as having a heart arrhythmia, it's all the symptoms seem to be the most telling thing, no? And also the symptoms and I guess the heart rate or when they're experiencing it. You do this through, I mean, the diagnostic tools are an ECG, which I'll just remind the audience is they put like these
Electrodes,
yeah
electrodes, chest.
suction cups, yeah, electrodes, and then
Yeah.
statements, and then
Yeah,
your it kind of comes out on this machine like graph that
correct.
and then
Yeah,
shows your heartbeat there, and then there is also the stress test, which consists of you like walking or running on a treadmill, and your
correct.
heart is monitored at that time, and then you can also take an ultrasound or like a 2D echo. Is that it? Yes, sorry.
Yeah,
Like you lie down on your side, and then they put this freezing gel on you, or maybe you just feel like it's freezing, but it's not really. And then this kind of like a device that's like I describe it really as like deodorant roll-on type. They just kind of roll
correct.
around that part to get like the
Yeah,
sound and images of your
correct.
heart. And then there's also the Holter monitor, which the Holter monitor, it's not heavy, right, doctor? It's just a very kind of small thing, like you're carrying
Yeah,
around a radio or a bag, if you like, and
yeah,
it records your heartbeats. I mean, it records when it needs to record. And as you said, so would you advise people like when, because you did mention documentation, so that means like, okay,
yeah.
observe yourself to like, when do you get these attacks? When do you get these palpitations? When do you get the symptoms? Um, and you mentioned like perhaps a patient will say, I felt, I got palpitations yesterday at 7 p.m. But you can look at then the Holter monitor and say, well, it didn't show that you had an irregular heartbeat at that time. Would you recommend that they go around documenting what they ate? And I mean, maybe that's for obsessive compulsive people like me sometimes when it's other people, like, you better write down what you ate, but would that be a good practice? Like, or at least just awareness of what you're doing at the time?
Yeah. So of course, to have what we call a cause and effect relationship, or to establish that, we need a diary wherein you write whatever you're doing or whatever you're feeling during the halter. I'll just emphasize that now we've had a deluge of patients because of the advent of wearables. So we have a lot of technology now. The wearables are, for example, the Apple Watch or the Galaxy Watch. So just to let you know, the number is not important. So, for example, if you have a watch that says your heartbeat is 120, the 120 doesn't say if it's a normal heartbeat or an arrhythmia. So what
Yes.
we need is something that records the ECG. So we need a step up from the pulse oximeter or the heart rate monitors that we used to have. And because now they're cheaper, we've had a lot of more patients having them. And it's easy because the patient just needs to press a button and it will record for 20 seconds or 30 seconds. It's unlimited. Once you get the gadget, it's basically free. So, for example, if you have an iPhone and you buy an Apple Watch, so it should be Series 6, 7, or 8. It cannot be the lower series or the special edition. And then it's virtually an unlimited halter.
Okay.
So if they have symptoms, they can just record at any time. The problem is if they have an irregular heartbeat and it's not causing a lot of symptoms, they might not be able to catch it because they need to press. Or on the other hand, if the symptom is a fainting episode and the fainting episode is sudden, they might not have enough time to press it to be able to record. And once they faint, of course, their fingers will go off. They will
Yeah.
not be able to hold the button long enough for it to record. So So what I'm driving at is that the wearables are a big help for us, but in some circumstances, or for example, some examples, we still need the halter because the halter will record whether the patient has symptoms or not. So it doesn't need any input from the patient. And if the patient's symptom is a fainting episode, it will still record even if the patient fainted. Whereas in the wearables, the patient needs to keep his or her finger on the button to be able to record. So
Yes.
because of the wearables, we've had a
Oh,
lot of patients coming in.
yes. Thank you, doctor. I mean, I'm so happy that you mentioned that because yeah, we tend to get carried away with not naman carried well we do, but it's a different, sorry, wrong context with our gadgets. And thank you for saying that. Well, at least some of our new wearables, or our phones, things we use all the time these days, I mean, there's a good side to it when it comes to this particular issue, or in this context, because they can monitor your heartbeat. However, you may not pay attention to it because you feel fine when you record it at that moment, or you need extra data. And of course, if you get the symptom of a fainting episode, there's no way you can guarantee you're pressing that recording button for 20
Correct.
seconds when you fainted.
Yeah.
And wow, so the phones do bring good things after all, aside, I mean, and not just stress from all the chats that we have. Okay. Yeah. Okay. Thank you, doctor. I mean, I'm sure that is such a big help, and that is a big piece of information. And also, just to remind some out there that if your cardiologist tells you you should wear the halter for a couple of days or 24 hours, maybe that's why they insist on it, because they need more of that data, whether you faint or not, and keeping it there in the documentation. But thank you for letting people know that they can at least rely on on things they use all the time, to have like a sort of monitor for that, a monitor type. And that you did say you've had a deluge of patients coming in because they have now sort of discovered for themselves that, hey, how come my resting heart rate is like this at this point? And they're more concerned with health. Okay, we have a bunch of, I'd like to read the questions from the audience. Oh, okay, sorry. We do need to take a short break for a minute, doctor. We'll be right back. And when we get back, straight to the questions. Okay, guys. I'm going to ask the questions already. Thank you, doctor. We'll be back in a couple of minutes. Stay tuned to Helpline with Makati Med.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. 𝗛𝗶𝘶 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable via Makati Med Mobile Care Access. As the name suggests, this service is mobile, which means that we go to where you are. Mobile Care Access deploys a team of professionals for face-to-face consultations and to conduct basic laboratory and diagnostic procedures, as well as vaccination and testing, depending on your needs. We can go to any location of your choice within the metro and readily offer these healthcare services to communities or groups. For added convenience, different modes of payment are available, including HMO benefits for those with a valid letter of authorization. We believe that access to affordable, quality, and compassionate healthcare is a basic human right, and we at Makati Med are doing our best to make this possible to more people. For inquiries, scheduling, or pre-registration, you may reach out to us at the following numbers. We look forward to coming to you and serving your community with Makati Med Mobile Care Access. Hi, this is Dr. 𝗛𝗶𝘶 and welcome to Makati Med Wellness Center. Located at Ayala North Exchange, the Makati Med Wellness Center is a warm and comfortable state-of-the-art lifestyle center where executive checkups and services that address holistic patient care and wellness can be done. We have a skin and laser hub, diagnostic imaging, health screening, mind and wellness care, and physical medicine and rehabilitation. The Wellness Center is equipped with modern facilities and staffed with competent healthcare professionals who are committed to deliver premium, personalized, and easy access healthcare services for both adult and pediatric patients alike. This is a great place to prioritize your health and well-being without having to be at the hospital setting. We are open from Monday to Saturday at 7 a.m. to 5 p.m. at the 7th floor of Ayala North Exchange, Tower 1 in Makati City. It is also accessible from the Makati Med Hospital through a bridgeway to Ayala North Exchange. For inquiries, you may reach us at these numbers. We look forward to serving you here at Makati Med Wellness Center.
You're back with Healthline, keeping you healthy. Moderated by Nicole Jacinto.
Hi, everybody, and welcome back to Healthline with Makati Med. I'm your host, Nicole Jacinto. We're here with Dr. 𝗂𝗶𝘁𝗵. He is a cardiologist or a cardiology specialist. We're talking about irregular heartbeats or heart arrhythmias. And Doc, I'll go straight to the questions. A bunch of people sent in some questions today, and I don't want to upset our audience. Yes, I'm straight to it. Okay, so I have to remove my glasses to read this properly. Okay, so doctor, okay, can heart rhythm issues be cured? Question I'd like to ask you. This is from Samuel of. Okay, I cannot read my teacher's handwriting. Samuel of. Samuel, sorry about that. It's not my handwriting.
Yes.
I can't read my own handwriting either. So
Now, when we say cure, Nicole, what we usually mean is that once we give a medication or intervention, it goes away permanently. So only a few arrhythmias or irregular heartbeats can be cured. So meaning, for example, as I said earlier, the young adolescent with a supraventricular tachycardia, once we do ablation, so it's a heart procedure, maybe 2 to 3 hours, we go to the groin, some catheters, they're like threads that we maneuver to go to the heart, and then we burn the what we call short circuit that is congenital.
Okay.
Once we do it, it will never go back again. The irregular heartbeat is gone forever. So there's some that we do ablations for just for symptomatic relief. So for example, atrial fibrillation. So it's an irregular heartbeat, usually prevalent in the elderly. If we ablate it, chances are it will go away for maybe a few months or a few years, but it can come back. So in that case, it's really not a cure, but it's something that we can do for symptomatic relief. Majority we just give medications. The medications are not cure, so they are what we call band-aid solutions. So the medications, as long as they're there, will achieve 4 things. Number 1, the patient will feel less symptoms. So the medication, once it stopped, will stop working also. So the irregular heartbeat or the arrhythmia might become more frequent again once we stop the medication. So it's not actually a cure.
yes.
Number 2, it can slow down the rate if the heart rate is too fast, or some medications can increase the heart rate if the heart rate is too slow, but that is not very frequent. Number 3, we want the patient to to have the confidence to live a good life, to have quality of life. So some irregular heartbeats are debilitating. So they feel it. They're very scared to move. They can't move because the heartbeat is too fast. So the medicines will help in that regard, but it's not a cure. It's not a medicine that we take for 1 month, and after stopping it, it will not go back again. So lastly, some medications are just given as needed. So meaning if the patient has an irregular heartbeat, they take it. It's what we call a pill in pocket strategy. So they have a pill in their pocket. When they have a symptom, the medicine they take, it will work in 30 minutes to 1 hour. The palpitation might go away. So in that regard, it stops the palpitation, but it's not cured, meaning chances are it will still come back. So ablation is usually, if it's done correctly, can be a cure. It can just be for symptomatic relief, but for most patients we give medications, but they're usually just band-aid. For bradycardia or slow heartbeats, the pacemakers are what we call curative, meaning if we implant the pacemaker, so there are devices that are implanted. So there's a battery underneath the collarbone, and there are 2 wires that are inserted into the heart, but we don't open up the chest.
Okay.
So they're like an internal battery, an extra battery, that when the heartbeat becomes too low, they artificially increase the heartbeat. So in that regard, it's already a cure because the bradycardia is gone as long as the pacemaker has a battery. So those are the strategies that we employ, Nicole.
All right. Thank you, doctor. So, okay, there is surgery, no? And that's either ablation, which means burning off something, or I guess restricting it. And you would be burning off something, structural in the heart that is causing.
Correct. Yeah, it's an irritant focus. Yeah.
Okay. And usually that's employed with younger patients. How long has that technique been around, by the way?
Sorry.
How long has that technique been around for
ablation? Many years, even before I was born.
Wow.
So, but yeah.
Okay.
So, but it has been perfected now. So before, when I was in training, we used to dread ablations because they would last 6 to 8 hours. But now we have 3D mapping techniques, computers, AI working for us, and we can do it as fast as 1 to 2 hours. It depends on, of course, the nature of the thing that we're ablating. And now it's very safe. Before it was, if the operator made a mistake and they ablated the normal heartbeat, the patient might need a pacemaker after a bad ablation. But now the complication rate is very low, and it's very fast and very easy to do now because of all the toys that we have, high technology toys that we have, especially in Makati Med. So it's an old technology, but now it's been perfected, ma'am.
Okay, we do that in Makati Med, no? And then, what does an ablation consist of? Like, do you go through general anesthesia, or, I mean, is it in and out procedure? Of course not. You stay a couple of nights, just the usual, overall description of it.
So for what we call the SVT, so these are young individuals, typically adolescents. They have an arrhythmia that's very fast. If we do the ablation, it's generally under local anesthesia on the groin, and then light sedation. So sometimes they'll fall asleep. Majority of the times they'll be talking to us during the procedure. We will, of course, they will have palpitations because we will induce or try to bring out the irregular heartbeat so that we can study it. And then once we ablate, after the ablation is burning of the congenital short circuit. So after the burning, we'll try to induce it again. If we cannot make it appear, then it's already gone permanently. So in that case, it's just normal sedation and local anesthesia. Usually the patient stays in the hospital for 2 days and 2 nights. And once the patient is discharged, we usually tell the patient we'll never see you again because
Yeah.
you'll not have the problem or same symptom again.
And
On the other end of on the other
sorry.
end of the spectrum,
Mhm.
for the what we call the atrial fibrillation, so this is an irregular heartbeat typically seen in the elderly or those with high blood pressure, diabetes, heart failure. So it's usually general anesthesia. We do have a lot of things, more equipment. So there might be a tube in the mouth. It's what we call an ultrasound of the heart. During the procedure, we need to go from the right side of the heart to the left. So we need to make a hole in the heart. And the ablation procedure is typically longer, maybe 4-6 hours, because we need to ablate more area. And the sedation is typically general. And then the patient stays in the hospital maybe 1 or a couple of more days than the usual SVT ablation. It is generally in the elderly and those who are very sick. So there are new technologies now that we have. Unfortunately, they're not yet in the Philippines. That promises that the procedural time will be shorter. There will be less steps, and we're looking forward to those technologies once they come to the Philippines. I'm sure Makati Med will be one of the ones with the first dibs in those technologies. So I'm looking forward to that.
That's great, doctor. So I mean, okay, so it's technically non-invasive surgery because for younger people you go through the groin. Is it non-invasive really? I mean, or less
It's a great, yeah,
invasive?
it's invasive, but you're correct. It's not an open heart procedure. Yeah, but we do puncture, so it's still considered as an invasive procedure. So, but small punctures on the groin, the patient if it's an SVT ablation, the patient might be talking to us during the ablation. The patient is bugging us. But if it's an AFib ablation, generally the patient is sedated, maybe even under GA, general anesthesia.
To go through the mouth to get
Yeah, for
into
the ultrasound of the heart. Yeah, so.
Yeah, it's funny how you said bugging you talking because I do that. I know I do because I've woken up during like an endoscopy and be like, oh, is that and doctor's like, shut up, like you're talking with
Yeah.
someone, but it really did happen. And also during dental surgery, I just wake up with anesthesia and I'm like, oh, so yeah, it can be like that. But I'm sure you guys find us funny when we're in that state because we just say the damnedest things. Okay, doctor. So, okay. Now, when it comes to pacemakers, when do you use pacemakers? That's also surgery. You implant the pacemaker.
Yeah.
As you said, it's up the collarbone, so that's like below your neck, your collar, and then there's battery. You said for bradycardia, if the heart is beating too slow, the pacemaker will take care of that. And in a sense, that's a cure as long as the pacemaker's battery is fine. What does that mean? Does the I mean, in terms of the battery, does that mean you change the batteries? Does it mean you get it checked? Or, I mean, how do you do that if it's implanted in your body and you don't leave a hole, right? I mean, it's there, it's permanently there. Okay. How does that work a little bit? I mean,
Correct, Nicole. So for devices, we have what we call therapy. So they're for slow heartbeats and they are the pacemakers. There's also the tachytherapy, the defibrillators. So for the pacemaker, if the patient has a very slow heartbeat, not enough to sustain the normal cardiac output, and the patient is symptomatic, or the patient's heart rate is too slow and there's a risk for the patient to die because of that too slow heartbeat, then the patient needs a pacemaker if it's not due to a reversible cause. So don't worry, when you see us, you don't automatically implant pacemakers without first determining if there's a reversible cause. So if there's a reversible cause, we will reverse it and observe. If the problem is solved, then you go home with peace of mind. So the pacemaker is inserted. So the patient goes in. Usually it's a 2-day, 2-night procedure. The patient goes in, gets sedated. There's maybe 1-inch incision underneath the left collarbone. So wires are inserted into the vein and they're screwed into the heart. But because of advanced techniques, we don't need to open up the chest. So we just work in a small 1-inch incision below the collarbone, either left or right. And then the lead or the wire is connected to a battery that is inserted underneath the skin. So everything is, we will not see any hardware over the skin or when we're finished. Everything is underneath or inside the body. So the pacemakers are intelligent. When the patient has a heartbeat, they will just observe if the patient's heartbeat goes out for some reason, then they will work. And the battery longevity depends on the model. For most general pacemakers, it's about 10 years or more. So it's a very long device longevity, because remember, most patients who need pacemakers are elderly. So for example, if we implant a patient in a 90-year-old and it lasts 100 years, 10 years, so they're already 100 years old, that's already good enough for most people. And once the battery conks out, we can just replace the battery. So when we say the battery, it's the unit.
Okay.
So with it, another procedure. So the tachytherapy is the defibrillator. So it's a scary thing when the patient presents to us with a fainting episode. So we need to find out if it's nothing, just like what we call a normal or a common faint, or it's because of a dangerous heartbeat. So if it's just a common faint, then we just send the patient home with some reassurance. If it's a dangerous heartbeat scenario, is the patient has a weak heart failure, the patient has what we call ventricular arrhythmias or dangerous heartbeats, which can cause cardiac arrest. So the defibrillator is just like, have you watched the ER scene?
You wrap the paddles and you're like, clear, and they
Correct. Yeah. So it's an implantable device that delivers exactly that, an electrical shock to reset the heart so that the dangerous heartbeat gets reset to a normal heartbeat.
So it just
defibrillator
does it by itself without shocking the
correct. Yeah, it's intelligent. So if the patient has a dangerous heartbeat that needs shocking, that the device will deliver exactly that. And the patient doesn't need to push any button, so everything's automatic. And the device also has a pacing backup. So if in the future, if the patient develops a bradycardia, so it's a tachycardia device, but if the patient develops bradycardia, then it will also have, or it will give the patient an artificial heartbeat.
Just very quick question, quick comment from you about tachycardia. I had a roommate in college in the US, and she said she had tachycardia and she got surgery, but they put the pacemaker in her ankle. So I'm like,
yes,
yeah, that can happen too.
I haven't heard of that in the ankle.
I was looking at her ankle, are you kidding me? like there, the above the ankle. I was like, okay, but anyway,
it's too far from the heart.
I know, because I was like, parang that doesn't sound right. Maybe she.
Correct.
Yeah. Okay. But it's really curious. Just curiosity. Okay. Thank you, doctor. You've told us about medicines for managing, and I was going to ask you what examples of some medicine are, but I'm guessing there's a long range. Let me go back to the questions because they are. Thank you for that question, Samuel of Taytay. It really induced a lot of answers. Okay. Okay. So we have a question from Isa, and even though doctors probably already answered this, still, what surgical options are available for arrhythmias? Isa, it's the ablation.
Yeah.
And the pacemakers.
Devices, yeah.
Okay. And then what's happening in the heart during an arrhythmia? Just, I guess, a quick overview again, Doc, for Luca James of Isabela.
So the heart is what we call a pump. So you need organized activity. So the upper chamber must contract first before the lower chamber. So if you have an irregular heartbeat, it's either the heartbeat is not regular, meaning it's not upper first and then lower. So meaning the lower can contract first before the upper, or the upper can contract at a very high rate, or the lower can contract at a very high rate. So imagine if the pump is not working, the upper and lower parts of the pump is not working synchronously. The efficiency of the pump suffers. So that's what usually causes the symptoms of the arrhythmia. Aside from of course, the irregularity might cause some symptoms. So what's more important is if because of the arrhythmia, the cardiac output or the blood going out of the heart becomes too low, there's a critical period wherein it can be as bad as a cardiac arrest or the patient can faint. On the other hand, if it's the cardiac output is the same, normal, because the heart's function is normal, the patient most likely will just need the medicine for the symptoms and reassurance because, of course, for the layperson, everyone out there, especially after the COVID, we're all very sensitive with what we feel. Sometimes if we feel differently, we're frozen, we're scared to death. We cannot do our usual stuff because we're afraid that the stuff that we do might trigger the arrhythmia. So that's why it's very important to go to your doctor, seek medical advice, because chances are whatever you're feeling that you feel might be something that is serious might not be. And you might just need a reassurance or a pill, and then you're just on your way back to your normal self.
Thank you, doctor. Thank you, 𝗛𝗶𝗁𝗁, for that. That was a great question, 𝗛𝗶𝗁𝗁. Thank you. Please do, join in any show anytime again. And then this is from Christine Ann of Makati. I just want to greet everybody, especially my family. Hi, Doc and Nicole. I love your show, always informative. Thank you, Christine Ann. And then, okay, Jessica is asking how a heart arrhythmia is diagnosed. Jessica, we went through that. Sorry, I'm just a bit rushing through because we are running out of time. The diagnosis is through as the doctor said, through the ECG, the Holter, the symptoms, and
wearables also very important.
wearables. Yes, Jessica, you can check your phone now. Thank you, Jessica. And then, hi, Doc. Can it be treated? This is from Pia. Yes, it can be treated, but not always cured. Can be managed.
Yes. Yeah.
Thank you, Pia. Okay, and then what is the treatment of arrhythmia? For Anonymous. Okay, well, Doc went through that. Thank you, Anonymous, for sending that question in. And then last one is from Amira. Hi, Doc. What is the life of a standard pacemaker battery? Okay, Doc went through that also. Okay, so about 10 years?
Yeah, about 10 years. There's some high-end devices that can last maybe 13, 14, or even 15 years, depending on the use. So again, it's just like a cell phone. It's not on all the time. Sometimes it's on standby. So if it's on all the time, then the battery longevity might be shorter. If the patient has heartbeat most of the time, then the battery longevity might be a little bit longer.
All right. Thank you, doctor. We are out of time, but if there's anything you'd like to say or anyone you'd like to greet, please go ahead and do so before we say bye for now and see everyone again next week.
Yeah, thank you for inviting me. Thank you for the time. I would like to invite everyone to visit us in Makati Med. So we do have we have a comprehensive suite of diagnostic tools, and we can either reassure you, cure you, or treat your arrhythmias. And it takes an expert mind, expert opinion, because expertise takes out the guesswork from medical practice. So we're not just going to go there and guess what's the diagnosis. We're going to find it out for you and prove it, and then reassure, treat, or cure you. Thank you, Nicole.
Thank you so much, doctor. Thank you for being on the show. Please come back and join us anytime to talk about anything that has to do with cardiology. Thank you so much, doctor. And thank you, folks, for tuning in, for listening, for sending in your questions. See you again next week on Health with Makati Med. Bye for now. Bye, doc. See you guys again. Bye.
Bye. Bye-bye.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of Healthline.
The views and comments of the hosts and guests are not necessarily those of the station.